hope you'll join us also for part 2 of this program tomorrow, which will be live stream at noon, same time as tomorrow. It is the same link that you used to join the program today. Tomorrow there will be a panel presentation, What is Happening in Kentucky. We'll be 3 individuals addressing the legal and investigative considerations on this topic. For speaker questions, please submit your questions in the Q&A option at the bottom of the screen. And before we begin, we do have a poll question, and we will launch that right now. So hopefully you can see the question on the screen. And there's a, there you go. So have you seen patients in your practice who may have been victims of human trafficking? Please answer that question. All right, you see the findings there. About 37% of you said yes. So that's a great preface for our discussion and primer. All right. So now we'd like to provide an introduction for Dr. Mollie Gordon and provide highlights to you from her bio. First of all, we really appreciate her joining us, knowing a hurricane is coming her way. And she said the weather's okay right now, but we're thankful that she's able to join us, and hopefully things are safe for her and her family the next few days. Dr. Mollie Gordon received her medical degree from the Washington University in St. Louis, where she also completed her psychiatry residency. In 2009, she joined the faculty of Baylor College of Medicine and currently is the Associate Director of the Inpatient Psychiatric Unit at Ben Taub Hospital. As a clinician, educator, and associate professor in the Menninger Department of Psychiatry and Behavioral Health Sciences at Baylor College of Medicine, she supervises medical students, resident physicians, and leads an interdisciplinary team in management of acute exacerbations of chronic mental illness using a biopsychosocial model. Dr. Gordon is a national expert on human trafficking, lecturing both locally and nationally, training teams of direct service providers in identifying and treating victims of human trafficking. She's a national speaker for HEAL, that's H-E-A-L, acronym, Trafficking, the Office of Trafficking in Persons, and other national organizations. In 2019, she co-founded the Baylor College of Medicine Division of Global Mental Health and directs a team of researchers and fellows in the study of violence and human trafficking as it relates to migratory, immigrant, and refugee communities. She and her team will be piloting an educational training program for healthcare professionals on human trafficking with the United Nations in 2020. So it's my pleasure to present to you Dr. Mollie Gordon.
Thank you, Dr. Honaker, for having me, and thank you for everybody for being here online. We have a lot to cover today, and we are going to focus on an introduction to human trafficking and how it impacts as a healthcare provider and what you can do about it in your practice. So as Dr. Honaker mentioned, I'm Dr. Gordon. I'm here at Baylor College of Medicine. Today I'm representing HEAL Trafficking, which is an organization founded in 2013 to approach human trafficking as a public health crisis. Previously in the field, human trafficking was addressed as a legal matter with a prosecution focus and not that there was a lack of healthcare approach, but by approaching this through a public health lens, we can take a look at the healthcare sequela to trafficking. HEAL has 3,100 multidisciplinary professionals, includes public health professionals, physicians, nurses, social workers, who all identify and research and treat trafficked persons. If you'd like to join it, it is a free group. Just go to healtrafficking.org, put in your email, and you can join listservs and follow the literature and follow their workshops and online groups as it relates to trafficking and healthcare professionals, or you can be more involved and get on committees and get more formal training. So we're going to start by talking about human trafficking and what it is in general. According to the United Nations Palermo Protocol, which is how we define trafficking in our practice, trafficking occurs when an individual or group has to use force, fraud, or coercion to induce a person into performing commercial sex and other labor acts. Now, Polaris, which has been the largest human trafficking hotline in the United States, it's almost 20 years old now, has defined 25 different types of human trafficking. And quite often, a lot of folks who are in the space of trafficking will talk about trafficking as it relates to child sex exploitation or sex trafficking, but we'll look up some data from Texas, and you can find that labor trafficking in the United States is a large issue that is unfortunately under-identified, under-treated, and under-researched. So please keep in mind that when we're talking about human trafficking, we're talking about all forms of trafficking, not just sex trafficking.
Hi, Dr. Gordon. Do you mind to share your screen?
Am I not shared?
It was, and then it's not now.
I don't know why it's not. Okay, hold on, let me double check.
Thank you.
Okay. Do I have to share every slide? It shouldn't, right?
You just click the green, it should be a green button.
Sorry, y'all, hold on.
Sorry about that. We were sharing it earlier and then.
I see us, hold on. I have a, hold on, that's not good. Because I have a slide, like a survey.
Okay.
Give me 1 second.
Sorry about that.
If I go into the Zoom app, how do I, or in the Zoom?
Do you see a green button at the top?
Yeah.
And then just click that and it should let you go to your presentation.
It's not, hold on.
Okay.
I'm in Zoom, but it is the Zoom meeting. It says chat meetings contact. I apologize, you guys.
No, that's okay. We can pull it up.
Here, I got it. Okay, let's see.
Got it?
Enter full screen, right?
Yes.
Okay. Is it up now? That work?
I don't see it.
Oh no.
It's okay.
What?
It's okay. We'll pull it up and then I will share my screen.
Is it working now?
It is not.
It says enter full screen when I share screen.
Okay.
I apologize.
Pull it. No, it's okay. I have yours right now, so I'll just pull it up myself. That works. Okay. And then if you don't mind, you can just tell me when to advance slide. Yeah.
Okay.
So I will do that now.
We should be on slide 3. It says human trafficking.
Okay. Just 1 second. Sorry about that.
We weren't even 3 slides in and we got glitchy.
Can you see my screen now? Thanks everyone for being patient. I think I got it. Can you see?
Yeah.
Okay.
I can see yours. I'm on slide 3.
Alrighty, I will get right there.
And to remind you, the website, healtrafficking.org is the website. I got that as a name.
I'm sorry about that, Dr. Gordon. If you don't mind, just let me know when I need to advance.
Okay. All right, so we're on slide 3. Okay, human trafficking. So minors cannot consent to the exchange of commercial sex. This was different than when I trained, because when I was a resident, we talked about child prostitutes, but children cannot be prostitutes. Children cannot be labor exploited. They can only be prostituted. And so force, fraud, and coercion is not required when we're talking about people under the age of 18. So sex work and minors, escorts, dancing, prostitution, that is trafficking, period, by federal definition. And so we're going to talk about a model, next slide, called the AMP model. That is a nice way of understanding the action, means, and purpose of trafficking, how it occurs, and why it occurs. So determining whether a person has been trafficked can be difficult if you don't take care of trafficked persons. And so this model highlights the action. So what was done to secure the individual, the means, which are the methods used to ensure compliance by that individual, and the purpose as to why that individual was taken, whether it was labor, sex, or debt bondage. So for example, actions can include things like recruiting, so targeting, grooming another person, harboring, isolating, confining, and monitoring somebody, transporting somebody, which is movement. We're going to talk a little bit about the difference between transporting and smuggling and trafficking later in the talk. Providing, which means taking somebody and giving them to somebody else. Obtaining, which is essentially kidnapping, which is very rare in the work that we do. Soliciting, so offering something of value, or patronizing. And then means is usually force, fraud, and coercion. And we're going to talk about it on the next slide, because force, fraud, and coercion can be lots of different things in interpersonal relationships. And then the purpose, as I mentioned, is sex or labor exploitation, and one of 25 different forms of trafficking. Next slide. So force is a physical concept. Is that person assaulted, restrained, harmed, monitored, confined? Is their physical freedom being restricted? That's what we think about when we think about forcing somebody. Is there a gun to their head, or are they physically unable to leave a room? Fraud is a little bit different. Fraud is a misrepresentation of what somebody's going to be doing. So it's a false promise. So it's either a romantic false promise, an employment false promise, an unexpected change in perception of what they were going to be doing. For example, I came to work as an au pair, but now I am being forced to work without pay for a family as domestic servitude. I was told I would be modeling, and now I'm being forced to work in prostitution. So it's a bait and switch. Coercion is a higher level of fraud, is a nice way of thinking about it. It's a threat of physical harm or force. It's psychological manipulation. We'll talk about how that works, because quite often I get the question of, why don't people just run? If they're adults, why don't they just leave? And then it's withholding of items of personal value or drugs to coerce somebody into a potential action. Next slide, please. So I'm down here in Houston, and we see a lot of trafficking. One of the reasons we see a lot of trafficking is we're a port city, we're an international border, we have huge corridors, I-10 going west to east, and 45 going south to north. So there's a lot of movement in our city and a lot of people. But there are also social determinants that allow for trafficking, what we call push factors and what we call pull factors. And those can occur on both an individual and a societal level. And that's what we call an ecological model to trafficking. So we're considered a hotspot. So let me give you an idea of the numbers of trafficking. According to the National Human Trafficking Hotline, that's the players group that I mentioned earlier, last year there were 2,700 contacts that came from the state of Texas, and they found that about 1,000 trafficking cases were reported. That seems like a lot, right? But what if I told you that in the world, there are 40.6 million persons who are currently being trafficked? Then 1,000 people doesn't sound like a lot, like we're doing much. And what if I told you that according to Dr. Armandez Bush and Dr. Melissa Torres' work at the University of Texas, that there's an estimated 313,000 persons trafficked in Texas, 79,000 of which are minors, and over 230,000 of which are labor trafficked. Okay, now that 1,000 number may sound large at the Polaris hotline level, but it's really small when we still have 312 of our 313,000 patients to identify and treat in the state, just in our state. So we're making a lot of medical systems and policy decisions on a national level based on that hotline data, that 1,000 persons who've been called in. And so what I'd like to do is start decisions based on larger numbers. Let's talk about Kentucky, because you guys are a little bit farther away from us. So according to the hotline data on Kentucky, there are about 400, I'm sorry, next slide. There are about 400 contacts that came from the state of Kentucky, and 136 cases of human trafficking were reported. So again, not a lot of numbers. When you think about it at a global level, if you're talking about 40 million people, 136 or 1,000 here or there really is just not even the tip of the iceberg. It's like the grain of the ice on the tip of the iceberg. Next slide, we should be on slide 8. And coming from Kentucky, there's a lot of different forms of trafficking that have been reported. A lot of the trafficking that was reported through, this is hotline data that comes from Kentucky, is sex trafficking, which is not uncommon. Labor trafficking is much less likely to be reported. It's harder to identify and may be considered things like labor exploitation or wage theft, and may be missed as actually the levels of force, fraud, and coercion needed to meet the federal definitions of trafficking. Top venues for labor trafficking include things like traveling sales crews. If anybody's ever had somebody come to their door, this actually happened to me once about 10 years ago. I had a boy knock on my door. He was a teenager. He was likely a runaway and was working for a magazine crew that was moving from city to city to city trying to sell me magazines. And then domestic work, and then food and agricultural services were also identified in the state of Kentucky as forms of labor trafficking that were reported to the National Human Trafficking Hotline. Top venues and industries for sex trafficking was resident-based commercial sex and massage parlors, which is sort of what we would expect from national data. And what's interesting is there is a lot of hotel and motel based data. So if you're a clinician and you're thinking about how does this relate to me and my patient, asking patients simple questions like, where are you staying? Are you staying in a hotel? How are you making the money to live and pay in that hotel, for that hotel room? Not surprising, we sometimes come up with answers that the patients are being exploited or forced to do sex work to pay the rent for that hotel. Okay, next slide, slide 9. So I want to focus here on the contact to the hotline. So if you think about those numbers from Kentucky, there's a lot of victims that reach out and call for help, which is wonderful. That's what the hotline is set up for. There are a lot of community members who observe things that look suspicious, or NGOs and nonprofits that work with trafficked or vulnerable populations or victims of violence that may reach out to the hotline and ask for help. But what's interesting here is that almost 30 of the contacts came from medical professionals, which is why it's important to be trained to identify and respond to trafficking when it presents in your clinical setting. This is a great article, next slide, number 10, slide number 10. This is a great slide because what it shows is that just this summer in 2020, the Department of Criminal Investigations got a call from Norton Children's Hospital. The Kentucky Cabinet for Health and Family Services and a group of Louisville advocates found minors that were being trafficked, and they were identified in a healthcare setting. A 17-year-old and a 19-year-old were rescued. So this occurred just in Kentucky, just this summer, and shows the importance of training healthcare providers to identify, recognize, treat, and respond to trafficking. So then the question becomes, next slide, how did somebody become a victim of trafficking? And I can tell you in our clinical experience, we've seen it all races, genders, creeds, socioeconomic classes, sexual identities, religious faiths, anything in between, in all ages. But there are some social determinants and social vulnerabilities that we know makes persons more likely to be trafficked. This data that we know comes from an article by a gentleman named Kerr, K-E-R-R, but the peer-reviewed literature actually looks at social determinants of trafficking. Unfortunately, only in 1 or 2 papers written by a gentleman named Perry, P-E-R-R-Y, and that looks at the social determinants in Southeast Asia, which is sort of relevant, but it's difficult to translate to places like Kentucky and Texas. But what we see clinically are some of the same social determinants and vulnerabilities across the United States. Things like homelessness, unaddressed psychiatric conditions, substance use disorders, migration vulnerabilities, which we call lack of immigration status, some personality traits and characters that make persons have a history of trauma and may attach abnormally to perpetrators, sexual and gender minorities, and then what we call system involvement. So in the family systems of like what we call DFPS or CPS, or children who have been in foster care or runaways. So there are a lot of different ways to recruit somebody into being, next slide, slide 12, into being trafficked. False job advertisements is the primary recruitment strategy for labor trafficking. Here in the United States, Signal International, here's a case example for you, faced a labor shortage after Hurricane Katrina damaged many of its structures. It's quite relevant today because there's a hurricane currently in Louisiana. So they recruited 500 workers from India under an H-2B guest worker visa program. And the workers paid $20,000 in recruitment and travel fees and were promised stable work and money to send home to their families and a pathway to citizenship. But when they got there, they found they were living in overcrowded, unsanitary spaces, were charged exorbitant fees that were deducted from their pay, and then threatened with deportation when they began to question the situation. That's labor trafficking. And so we see this in our communities. Disasters and natural disasters are a risk factor for trafficking. We're actually writing a paper right now about that. And then there's other ways to recruit folks into trafficking, including romantic seduction. That's a very common recruitment strategy for sex trafficking, where intimate partners or prospective romantic partners initially create an attachment and then switch to become a perpetrator. And they use those manipulations, coercions, and fraud, like we mentioned, like I mentioned earlier in the slides, to force people to engage in sex acts for financial gain. We also see family-controlled trafficking, and we'll look at our data. We see quite a lot of this, unfortunately. So sometimes trafficking occurs by family members in the home, and then as that person ages into adulthood. And then when children run away from those situations, they are vulnerable to exploitation later. Next slide, slide number 13. So how do you keep somebody in a trafficking situation? I get this question a lot. Why don't people run? Why do they stay? And Susie Baldwin wrote a beautiful paper. She is a primary care doctor out in Los Angeles, and she works for the Department of Health and Human Services in LA. She wrote a beautiful paper talking about what we call the Biederman model of attachment. And the Biederman model, if you're interested in history, comes from Biederman, who studied in 1957 Korean War American prisoners of war in Korea, who were coerced into confessions that were false. And so they were not forced by physical harm and torture. They were actually forced by psychological coercion. And so what Susie Baldwin and her team found is that the same methods that Albert Biederman found in prisoners of war to confess to crimes they didn't commit were found in victims of trafficking when interviewed about the mechanisms by which the trafficker was able to coerce and force somebody to behave in a particular manner without necessarily physically harming them. And so some of those psychological coercive measures include things like isolation from an individual from their family, what we call monopolization of perception, where people become romantic partners or surround the victim with friends who are all involved in trafficking, so that the only world they see is one of trafficking. Induced stability and exhaustion, having them engage in sex or labor work to the point of physical exhaustion. Psychological and verbal threats. If you don't do this, I'll harm you or a loved one. Or witnessing violence, so they never harm the victim, but that person engages in a violent activity in the presence of that person, and they say, well, they could do that to them, they may be able to do that to me. Occasional indulgences, so a world of violence, isolation, and control, and then intermittent love and reward, presence, freedom, etc. Demonstration of what we call omnipotence, so that person is above the law, that person is the only person who makes decisions, that person is the emotional controller of somebody's actions and behaviors. Verbal and critical degradation, and then what's called enforcement of trivial demands, having a person do things that are not labor and sex trafficking to illustrate a sense of control. And so if you want to read a little bit more about these methods, feel free to look at Susie's paper. Then there are other physical compliance methods, physical violence, the use and force of drugs and alcohol, and then the abstaining of drugs and alcohol to force somebody to go into withdrawal state, or then threats and withdrawals of immigration, withholding documents, or basic need items. Next slide, please. So this was a really nice paper that was done by Lederer. She's actually a lawyer. She's not a clinician. And she found that somewhere between 67 and 88% of human trafficking survivors reported seeing a healthcare professional during the time that they were being trafficked, which means 2/3 of patients who are trafficked will come into contact with a healthcare provider. So then I get this question a lot, which is, who do they see? Well, they're more likely to see you guys than me. They see ER doctors, PCP, obstetricians, dentists, and then sometimes pediatricians, adolescent medicine doctors, and psychiatrists. They're not going to come into an ER and say, I'm being trafficked, I need to see a psychiatrist. So they'll come into an emergency room with medical conditions that we'll talk about later that present in a sort of what we call red flag pattern. And how that's been effective in identifying and responding to trafficked persons. Next slide. Our program was created in 2016 after myself and my partners, Dr. Coverdale and Dr. Wynn, on our inpatient unit, noticed that a lot of our patients were reporting trafficking and had a lot of medical, psychiatric, and social unaddressed needs in their care. And so our program was developed to provide both medical and psychiatric services to trafficked persons and connecting them to what we call bidirectional social workers, one in the hospital and then social workers in the community. Next slide. We engage in screening of trafficked persons, coordinating their medical and psychiatric care, ensuring primary follow-up with a psychologist and a psychiatrist and a social worker, and then educating healthcare providers and community partners on trafficking, and then researching the impact and the outcome of our model. Next slide. In the last 2 years, we have received 440, as of this week, almost 450 referrals, 70% of which were trafficked. So let's go back to those numbers I talked about at the beginning of the slide. So in 2019, there were 1,000 calls from Texas, the whole state of Texas, to the human trafficking hotline. In the last 2 years, on a 20-bed inpatient psych unit in Houston, we've seen 450 referrals, 2/3 of which, so probably close to 300 of which are trafficking, which goes to show you that these patients are all across the healthcare system. They're not being reported at the numbers we probably predict to the National Human Trafficking Hotline, which is why it's important for healthcare professionals to know about trafficking, to be able to identify and then make these referrals. About half of these referrals came from our community partners who knew about our program, and then close to the other half, or 60%, came from either our inpatient unit or through our emergency room, and a few came from our outpatient providers. Next slide. As I mentioned, family-controlled trafficking is unfortunately very common in the United States. About 1 in 5 of our patients were part of a family-controlled trafficking ring, and almost half of the patients disclosed sex trafficking as a child. Also of note, our ACEs data, this is not published data yet, so what we call our Adverse Childhood Event Score, or Adverse Childhood Event Scale, which is a scale of looking at adverse childhood events that occur: divorce, incarcerated parents, parents with severe mental illness, violence in the home, etc. It's a 10-point scale. Many of you may be familiar with it. You know, most persons have maybe 1 or 2 adverse childhood events, and our patient population, our average was about 8.5. So another great screening concept is to consider, you know, a child's developmental history and adverse childhood events. And if those scales are high, what does that tell you about that person's risk for being trafficked? Next slide, please. The patients that we see are not children. As I mentioned, I'm an adult psychiatrist. We work on an inpatient adult unit, and the majority of the patients that we see and are referred to are between the ages of 18 and 44. So this is trafficking of a grown adult. This is not trafficking of an exploitation of children who may be even more vulnerable. And so this is something to consider, not just in your pediatric population, but in your adult population that you see in your clinics and your emergency rooms. Next slide. Another question I get when I tell people the kind of work I do is this assumption that I work in international global health and I work in human trafficking with a Southeast Asian sex trafficking population, which is, yes, trafficking occurs in all countries, but this is not at all what we do and see here in Texas and in the United States. A third of our patients are Caucasian. About 45% of our patients are African American, and we're in Texas, so about 25% of our patients are Hispanic or Latino. We do have a lot of Latin Americans here in the state. But what you'll find is that these are domestic, multiracial victims, and our Asian community, either they're not coming into the hospital and they're not seeking care, so that's one possibility, but they are African American, Hispanic, and white. So keep in mind when we think about stigma and perceptions of trafficking and how it impacts our own personal community. Next slide. So what we developed was what we call a recognize, respond, and refer model of care. And this is something that can be translated across hospital systems in the United States. We have done something called a 1010 fellowship, where we've described this model of care to other cities and municipalities across the United States and actually international, with our city leaders and our mayor, and we're able to train other healthcare institutions to do a very similar thing, and it's not too complicated to implement wherever you are. Next slide. So the first thing to do as a provider is to be able to recognize trafficking as it comes into your healthcare system. One of the things that's important to consider are social determinants and what we call converging vulnerabilities. So those high ACE scores that I mentioned, or multiple risk factors that would make somebody vulnerable to being exploited, such as severe and chronic mental illness, states of homelessness, substance use disorders, psychiatric conditions, personality conditions, gender minorities. Now, as I mentioned, we see plenty of patients who don't have those social vulnerabilities, but these are things that you should consider when you're seeing patients of those cohorts. Patients in their history will look like they'll have what we call variability of latency. So if you ask them a question that they don't have a scripted answer to, they may be a little bit more latent or hesitate before they answer a question. And when they answer questions by multiple different providers, the answers will be unusually scripted. The patient may have a history of abuse in other ways, a history of verbal, physical, sexual abuse in childhood by intimate partners. There may be identification issues, different names, date of birth, aliases, identifications on the person. Next slide. There may be environmental cues as that person presents to your emergency room or your clinic. They may have somebody accompany them to, in the exam room at all times, not wanting to leave. They may not be clear when they're working with interpreters because of fear that somebody in their community may identify them. They may not have things that a patient should have, their phone, their ID, their wallet. There may be discrepancies in history. So somebody may be either hyper scripted or markedly inconsistent. They may tell social work one story, this is my dad, and they may tell, the doctor something else, oh, this is my brother. And discrepancies that shouldn't be so discrepant or changed. And then obvious issues of safety concerns. Things like, does that person have food, shelter, and then, are they in physical harm's way? Do they have signs and symptoms, which we'll talk about next, of physical harm? Next slide. If a patient comes in to see a provider and there's been a physical assault or a sexual assault recently, exploring the not necessarily the details of the assault, who the perpetrator was, but the patient's relationship to the assailant. Did the patient know the assailant? Why was that person in the room in the first place? Was somebody forcing that person to be in contact with the assailant? Was it someone they knew, or was it a stranger? And when we talk about the physical manifestations of trafficked persons, I think about it from a medical perspective as either sort of what we call psychosomatic symptomatology, symptoms of neglect, or consequences to labor and sex trafficking. So if we talk about things like psychosomatic symptomatology, patients present to their provider with vague constitutional symptoms, weight loss, change in appetite that don't meet criteria for depressive symptomatology, soft neurologic symptoms, intermittent headaches, dizziness, memory problems, GI symptoms, unexplained abdominal pain, nausea and vomiting, unexplained cardiovascular symptoms like intermittent chest pain, breathing difficulties, chronic pain syndromes like back pain or pelvic pain syndromes, rashes or neglect for their physical care. And then when, so symptoms that may be physical manifestations of a highly stressed state. Then there are medical presentations that imply that the patient has been neglected. So their access to care issue becomes a presenting red flag. So why is this person not getting treatment for their blood pressure or their thyroid disease or their diabetes? Why have they had this mass, lesion, wound, dental infection, cut, injury, and it's been neglected, and now there's this infection and it could have been treated? Is there a urinary tract infection that's quite benign and now it's gotten to the point that the patient has pyelo? Why did the patient not come to the hospital sooner and get access to care? And then the third kind of grouping of physical symptoms would be secondary to the trafficking experience themselves. So if we're talking about sex trafficked persons, we see a lot of choking and strangulation issues, loss of consciousness issues, secondary substance use and substance withdrawal presentations. We see a lot of pelvic infections, pelvic trauma, anal trauma, and then bruising and physical assaults that may occur during sexual activity that may be violent. And in labor patients, we see repeated stress injuries, and then injuries of exhaustion. So somebody's not getting hydrated, especially down here in Texas. They're not getting enough water. You see heat stroke and extreme sunburns where a person should have had physical coverings, OSHA violations if somebody's working in a position where they should have protective equipment, or they're exposed to chemicals or an injury that shouldn't have occurred while on the job. So those are the kind of medical considerations to think of when a patient presents to you when you're looking at their physical signs. We talked a little bit about neglect of medical conditions, but also maltreatment and abuse. Injuries in various stages of healing is something you see in both adults and children. There are also some tattoos. Now, the tattoo paper, I have to disclaim, tattoos are very common in the United States. So 30% of folks have tattoos. So tattoos don't mean that the patient is being trafficked. But we did write quite a nice paper in the Journal of Nervous and Mental Diseases a few years ago about particular tattoos that are associated with either gang-affiliated trafficking or control by a trafficker or a pimp. So, dollar signs, names, ownership, references to money, particular areas like on the neck, on the pelvis, across the chest. What we call brandings, barcodes are much more rare, but they've been talked about a lot in the literature. And so asking patients about their tattoos. Who gave you this tattoo? Who's this person on your body? Who put it there? Did you make that choice, or did somebody else make it for you? And then like we talked about, reproductive indicators. So somebody who's had repeated untreated sexually transmitted diseases, or multiple miscarriages. Not uncommonly, we'll see some women who come in and they've had like 12 or 13 miscarriages. So is there a hematologic reason why, or is there an access to care issue why, or is there a traumatic reason why? Next slide, please. From a psychological or psychiatric perspective, we see all sorts of variants of presentation. So we see much more negative symptomatology, like depressed, withdrawn, isolatory symptoms. Patients present to healthcare providers with externalizing behaviors such as self-harm, suicidal behavior, conflicts with others that may be identified as or concern for homicidal ideation. We can see patients that are illustrating symptoms of PTSD and trauma. They're very anxious, hypervigilant, guarded. We can see selective mutism in adults, hesitant to engage with a provider or divulge personal information. And then at some point, either because the patient has a drug-induced phenomenon or a primary underlying psychotic disorder, we see auditory and visual hallucinations that have concerning themes of violence, trauma, and exploitation. We can see psychiatric symptoms that predated the patient's trafficking. And then we see psychiatric symptoms that are, of course, post-dated or psychiatric sequela of the trauma itself. And in some cases, we see both. Next slide. So questions I get often are, how do I ask a patient if they've been trafficked? So The Polaris project has a lot of really nice screening questions. The Polaris project website has a lot of nice screening questions. There are no validated screening questions in a healthcare setting for traffic victims other than Jordan Greenbaum's work in pediatric emergency room settings. And so some questions we like to ask that are general are things like, have you ever been lied to about a job? Have you ever been forced to have sex against your will? Have you ever been asked to do something you didn't want to do? These are sort of vague, large, general questions. And so asking questions like, where do you sleep and where do you work? And are those the same place? And can you leave freely? And who has your identifying documents? And then more specific questions, such as, have you ever worked in sex work, dancing, escorts, prostitution? How old were you when that happened? So if you have a 15-year-old boy or girl who's working in the sex industry, that's a gimme. That's sex trafficking. You don't need force, fraud, and coercion to be concerned about trafficking in that situation. It's important to make sure when you're talking to patients about trafficking that you evaluate that patient's immediate level of safety and danger. Is the trafficker in the room with the patient? Is there somebody there that could be a potential harm? And asking these questions could put that person in more harm. Explaining your role as the provider and the reason you're asking these questions. I tell patients, I screen everybody for violence. We live in a city where there's a lot of things that happen to people, unfortunately. And so I ask everybody who comes to my unit these questions. Sometimes patients find it silly and unusual, and sometimes patients are relieved I finally asked them about trafficking. Just this morning, we have a patient who's been trafficked for 10 years, and my resident identified the trafficking in the emergency room last night, and nobody had asked her, and she's been in our emergency system numerous times. Start the conversation with more benign, less intrusive questions. Don't jump in and with questions about violence and safety. Easy questions like, do you have allergies is always a good way to start. And then explain bounds of confidentiality and the right to disclosure. And I think there will be a lawyer talking with you guys later about HIPAA and confidentiality and rights to mandatory reporting and rights to disclosure. But sometimes those questions, next slide, sometimes those questions are not easy to ask. We should be on, I think, on slide 28. So either the patient doesn't want to disclose that they're being trafficked, they're ashamed, they fear that they may be retaliated against or harmed, they don't trust the provider, they don't know that there are resources to help them, so they feel futile. What use is it? And sometimes the provider doesn't want to ask. And so they may be busy, they may not know what to do once the person screens positive, they may have burnout, compassion fatigue, they may be seeing violence all day long and really at the point in their day where they just don't want to hear about more violence. So recognizing both the provider-centric and the patient-centric side to barriers to care is important to making sure it doesn't impact your relationship with your patient. Next slide. Sometimes we see things that look like trafficking, but they sound like something else. And so we're going to look at a couple of cases here. So we have we should be on slide 30. We have a 35-year-old male who presents as a code 1 after he had a nail injury during a construction accident. He disclosed to the team that he paid a coyote, that's a Texas term for a smuggler, to move from the Mexico to the Texas border. $8,000 travel from Honduras through Mexico to the United States, made it to Laredo, and then was told that he had to pay $5,000 for unforeseen issues during the trip. He was told he could work in a restaurant to pay off the debt, and then was put into a stash house with 20 other men, taken to a farm where he would work 16 hours a day for inconsistent wages to avoid an effort to resolve this debt. Now, the question I get often is trafficking smuggling? So I should clarify that human trafficking is a crime against a person. Human smuggling is a crime against a border. So you can be smuggled and trafficked. You can also be trafficked without being smuggled. You can also be smuggled without being trafficked. Occasionally they go hand in hand, where a person has two issues at play. They are both moving across a border and they also have a violation against them, but they can be also mutually exclusive. So not all smuggling experiences are forced, frauded, and coerced. If there is forced, fraud, and coercion, then trafficking exists. I think I made all those. Oh, and I should make this other comment. Sometimes patients who are smuggled from borders, so remember smuggling is a violation against the border, experience violence during their smuggling. But that doesn't mean that they're trafficked, because they have to be force, fraud, and coercion for the financial exploitation of a third party. So they may incur violence during smuggling, but that doesn't mean they were trafficked. Okay, next slide. Here's a case study of a fictional patient named Sarah, 22-year-old female patient who came in for pelvic pain and vaginal discharge to the emergency room. During exam, the physician noticed that she had abrasions and marks. When asked about safety, she said she's safe because she is now self-employed and had used to have pimps for protection, but was able to sever ties with the pimp when he went to jail and is now in full control. So this is a bit of a complicated case because this patient has a history of trafficking, but is now working in sex work. And so sex trafficking and sex work both include the exchange of sexual goods for money. In sex work, the individual or the patient makes the choice to engage in that process. In trafficking, that person is forced by somebody else to engage in that process. So both involve similarities in engaging of sex for money, but one is by force and one is by choice. Next slide. Here's a case of Maria, 18-year-old female brought in by EMS after a suicide attempt by strangulation. Collateral from an adoptive mother indicates that the patient had an extensive history of neglect and abuse in childhood. We talked a little bit about ACEs. Multiple inpatient psychiatric hospitalizations and self-injurious behavior, and that the behavior worsened after an incident with a boyfriend. At a party, the boyfriend drugged her and allowed multiple individuals to rape her while unconscious. By facilitating this, the boyfriend was able to pay back a debt that he owed to a gang. Now, again, this is a bit of a complicated story because there was a sexual assault. So a patient engaged in sexual activity without consent, but that sexual assault had a financial gain to a third party, which is what makes it trafficking. So a debt that her boyfriend had was paid off by forcing her to engage in sexual activity for his economic value. So if that young lady had been sexually assaulted by these persons at a party, it would be a sexual assault. If that assault occurred because of a financial remuneration and it was forced upon her and there's force, fraud, and coercion, then it meets the criteria for trafficking. Next case. This is Joe, a 40-year-old male who comes in for depression and anxiety in the context of a relationship stressor. He has a long history of an abusive relationship where drug use was the norm in that intimate partner relationship. The abuse escalated when the partner was laid off and there was financial stress. The partner suggested that Joe began panhandling to earn money. He hesitated and this partner would become verbally and physically aggressive. So now you have force, physical force. Joe complied and began selling items door to door to patrons and to patrons exiting grocery stores, and 100% of his earnings went to his partner, who used them to buy drugs. And then he was kicked out when he asked about his own employment plans. So there is an overlap and an interface between human trafficking and domestic violence. Both crimes involve psychological manipulation and can cause physical and sexual harm. Abuse and violence in the home between intimate partners did not necessarily equate to trafficking unless there's an exploitation for financial gain. And so in this case, because there is a forced behavior and a violence that occurs and then a third party gets a financial gain from it, it's considered trafficking, even though there's a romantic relationship and even though it also meets criteria for domestic violence. So, so trafficking on its own in a box, like we talked about with the AMP model, is an action, a means, a purpose, and that means is by force, fraud, and coercion. But not uncommonly, trafficked persons are victims of domestic violence, are victims of smuggling, are victims of sexual assaults, and are victims of forced labor and debt bondage. Okay, We're almost done. We're doing great. Next slide, slide 34. This is a really nice paper that was actually done out of Kentucky. This is what we call the YES study. And this study highlights the importance of screening homeless youth, which we talked about as a vulnerable population for trafficking, for past, current, and at-risk for future exploitation. The study addressed both the mental health and the medical symptoms and responded to patients in a trauma-informed way when there was any sort of suspicion or disclosure of trafficking. So in these children who were experiencing homelessness, the PIs recognized that many of the patients had a history of substance abuse, a history of suicide attempt. But what's interesting here is that while 73% endorsed a current mental health problem, almost 60% had a concurrent medical condition that needed treated. Of 132 homeless youth, 40% of these children had a history of sex trafficking. So easy questions are things like social determinants, homeless youth, medical comorbidities, and then a history of trafficking. So this next slide brings me to a conversation about what we call a trauma-informed approach. And in this situation, we need to understand that a patient's remote or even current and recent trauma may be influencing current behaviors, beliefs, affects, dynamics between the provider and the patient. We need to recognize symptoms of PTSD that may be both internalizing, so patients may be isolative and withdrawn, or externalizing. We have to be careful about triggering patients by asking a lot of questions that may meet our curiosity, but may not be clinically relevant and can be re-traumatizing the patient. The recognition that we are not a patient's superhero or rescuer. We are here to recognize patient symptoms, provide them resources, and get them access to healthcare. We're also not here to try to get a disclosure from a patient or to try to convince a patient to leave their trafficking situation. The trauma-informed approach that was developed by SAMHSA, there's nine characteristics of a trauma-informed approach. We're not going to go into those now. Focus on reinforcing a patient's strength, focusing on healing and harm reduction from both a mental and medical care side, and then developing resiliency within the patient. Next slide. Cultural humility is also something that comes up often when we talk about trafficking and a trauma-informed approach. Cultural competency was how I was trained. It consisted of 4 domains, which includes awareness, knowledge, cross-cultural skills, and attitude. But that implies that we can be competent in the culture of another, which is something that is difficult to do. Cultural humility looks at relationships with others' cultural experiences as an ability to maintain a stance that is other-oriented in relation to the aspects of identities that are most important to the person. So simply put, is understanding when something is different than ours and creating a lifelong evaluation to partnering with that other person in their social experience. So this includes communicating openly with your patient, recognizing the patient's gender roles and how that fits with your gender role structures and beliefs, differences in sexual orientation and religious values, the community in which that person may have been brought up may be different than yours, as well as their socioeconomic status, and their perceptions of both mental health, medical care, and then the mental health and medical care providers may be different than our own. Next slide. If you're concerned that you may come across a person that has what we call red flags for being trafficked, again, disclosure is not the answer, and separation from the trafficker is not the answer. The answer is reducing harm and referring that patient to resources that can continue to help support them during their experience. So that includes connecting them to shelters so they have safe food and housing where they may not need to exchange those for sex or labor. There are residential treatment shelters and residential treatment programs for minors across the United States. This is much more difficult when it comes to labor trafficked individuals and it comes to men and LGBTQ youth. There are community-based case managers that specialize in focus and trafficking. There are task forces in most cities, which includes a combination of healthcare providers, NGOs, leaders, and law enforcement. There are many initiatives and faith-based groups that focus on helping to support trafficked persons in the community. And of course, there's substance abuse treatment options for trafficked persons specifically. Usually when I do this talk in a group of persons live, I'll ask everybody to repeat the National Human Trafficking Hotline number at the beginning, and then I'll check at the end. We're on slide 38, so I'm gonna have everybody think to themselves the hotline number is not as fun on Zoom, but it's a palindrome, and it was made that way to be easy to remember. It's 888-37-37-888. And you can say it backwards, 888-37-37-888. So it's easy for patients to remember without having a doctor or a healthcare provider write it down and risk being found by the patient's trafficker. So if that's the only thing you remember from this entire talk, hopefully you will be able to connect a trafficked person to a resource. If you call that number on the National Human Trafficking Hotline, they will be able to provide the provider with resources for that person wherever they are in the country. So if you're in Kentucky, Tennessee, Texas, California, no matter where you are, if you call that number, and substance abuse treatment programs that I mentioned in your area. If you have any questions or for more information, please feel free to look at our website, email me directly at recognizeht@bcm.edu. And again, please consider joining healtrafficking.org to connect to other healthcare providers who are interested in stopping trafficking in their healthcare systems. I think we're done.
All right. Thank you, Dr. Gordon. Appreciate your time. All right, there's my video. Thank you for your time, and thank you for the very educational discussion. Appreciate you being with us. I have one question in closing for you, as we have limited time. But here's the question. So what public message can be had to people to empower them and prevent them from becoming victims? So what kind of things do we tell our children? Do we tell those who are vulnerable, those that we know are at risk, to make sure that they don't make decisions to get themselves in high-risk areas? And obviously some people are victims, and it's not like they made decisions to get there. But what can we do to help people make sure they're not at risk to become victims?
Oh, that's a very complicated question. So that's what we call primary prevention, right? So how do we prevent trafficking from occurring in the first place? So I think when it comes to our community and our own children, talking to our friends, family, children, and community members about ownership. So who makes decisions about one's self and actions? And so recognizing the dynamic that that if somebody is making you do something that you're not comfortable doing, that's something that needs to be reported to somebody who's trustworthy. And having there's a lot of great data about having a trusting adult actually being a mitigating factor for trafficking. So connecting children to a trusting adult in their community, or even connecting adults to a trusting adult in their community they can reach out to if they feel like the decisions and the ownership that they make about their living situation, their social situation, their financial situation, or their bodies are not their own.
Yeah, it seems like so much of this starts with deception. So empowering people to think about what could be deceptive practices is probably a great message to share. Thank you, Dr. Gordon, for being with us today. We do want to re-ask the polling question that we started with, so we get a sense of your answers pre and post discussion. So the question's back up on your screen again. Have you seen patients in your practice who may have been victims of human trafficking? And we recognize the number were not with us in the beginning. And even if you were in the beginning, please answer the question again, because how you identify victims of human trafficking may have changed from the presentation. All right, the number went up. I believe it was 37% pre-discussion, and now we're 51%. Obviously, a little bit different bias. We have a bigger cohort at the end of 141 people versus the 70 plus people to begin with. So with that, thank you for engaging and being part of the presentation. Thank you again, Dr. Gordon. Here's some reminding closing remarks. The reminder of your evaluation for credit, in addition to an email, when you exit this webinar today, you will see a link to SurveyMonkey. Select the Continue button for the evaluation and credit. Reminder, once you submit the evaluation, you will continue to claim credit. We hope to see you tomorrow for part 2 of this live stream, which will take place tomorrow also at noon. The subject is a panel presentation, and it'll be entitled What is Happening in Kentucky? Addressing Legal and Investigative Considerations. So to join Friday's program, it is the same link as today. In a couple of weeks, today's program will be available online at nortoncme.com. An email will be sent when it is available. So thank you for joining us today. Thank you, Dr. Gordon, and have a great rest of the week.